Hello, welcome to my channel. So today we're looking at the special senses. So we both go through the anatomy and the physiology of special senses. So the senses that we have discussed, we have the general sense of touch, which is the tactile sense, and it's actually look at the or its senses temperature, which has the thermoreceptors, so the pressure, the mechanoreceptors for movements as well, and also pain, also for mechanoreceptors. Now, the general, this specifically is the general sense, and it falls under the integumentary system. So with this one, we have already done. So, but today specifically, we'll be looking at the spatial senses, where I'll talk about the sense of smell, the sense of taste, the hearing, the sight, and the equilibrium. Then you have to learn that hearing and equilibrium are all mechanoreceptors, and they are all found in the ear. So meaning the ear has a sense of um, hearing and the sense of equilibrium. Okay, so we are saying we are going to go through the special senses such as the smell, taste, hearing, and equilibrium, then sight. But of course, we are going to start with sight. Okay, so that's what we are saying. So smell and taste are chemoreceptors, so meaning they use chemicals. Then hearing and equilibrium are mechanoreceptors. Then sight is a photoreceptor. Okay, so let's start with the eye. So we are starting with the eye. So the eye and vision, that's what we are going to start with. So which of course has photoreceptors. So 70% of all receptors are in the eye. So each eye has over 1 million nerve fibers, and protection for the eye comes from, or the protection from the eye comes from the bony cavity. So that's what you have to note. Say that most of the eye is enclosed in a bony cavity, the bone orbit. So the bone orbit is one which actually protects the eye. So what is the bone orbit made up of? The bony orbit is made up of the lacrimal, which is the medial. You have the ethmoid, this is the posterior part. You have the sphenoid, which is the lateral part. You have the frontal, which is the superior part. And finally, you have the zygomatic, and you have the maxilla. Then, accretion of fat also surrounds most of the eye. So these two are what protects the eye. Okay. So let's look at the accessory structures of the eye. The accessory structures of the eye. So number one, we have what we call eyelids. So eyelids, this just brush particles out of the eye or cover the eye. So the eyelids specifically we're talking about are these ones. We have the upper eyelid and we have the lower eyelid. And we are saying the function of the eyelid is to brush particles out of the eye or cover the eyes. Then we have the eyelashes. The eyelashes, these are the eyelashes. Okay. The hair that you are seeing, those are the eyelashes. So the eyelashes trap particles and keep them out of the eye. So those are the eyelashes. So we are still on the accessory structures of the eye. Next accessory structure of the eye is the ciliary glands. So ciliary glands are just modified sweat glands that are found between the eyelashes, and they secrete acidic sweat to kill the bacteria. So those are the ciliary glands. So apart from killing the bacteria, they also lubricate the eyelashes. Those are the ciliary. Those are the eyelashes. And we are saying the ciliary glands secrete acidic sweat to kill bacteria, so lubricate eyelashes. Okay. Then next accessory structure we're going to talk about is the conjunctiva. So the conjunctiva is a membrane that lines the eyelids. It connects to the surface of the eye, forms a seal around it. Okay. Then you have the same conjunctiva also secretes mucus to lubricate the eye. The same conjunctiva also secretes mucus to lubricate the. Then we have a medical term or medical terminology, which is conjunctivitis, which is a medical condition. So conjunctivitis is inflammation of the conjunctiva and can be caused by bacterial or viral infections, and this is highly contagious. Then we have other accessory structures of the eye, such as the lacrimal apparatus. Lacrimal apparatus. So I mean it's called the apparatus because there's a lot of structures on it. So number one, we have the lacrimal gland, which produces lacrimal fluid. Then you have the lacrimal canals, which drains lacrimal fluid from eyes, which drains lacrimal fluid from the eyes, the lacrimal canals. Okay, then you have the lacrimal sac. Lacrimal sac provides passage of lacrimal fluid towards the nasal cavity. Lacrimal sac provides passage of lacrimal fluid towards the nasal cavity. That's the lacrimal sac. Okay, lacrimal sac. Then another accessory structure found on the lacrimal apparatus is the nasolacrimal duct. This one, the nasolacrimal duct. The nasolacrimal duct empties lacrimal fluid into the nasal cavity. So this one empties the lacrimal fluid into the nasal cavity. That's why I find that most people, when they are crying, they are also mucus, altered mucus is also coming out. So that's just to say tears and the mucus produced by the goblet cells found in the nose are mixed. So someone can be crying also. They are also moving also mucus also moving out of their nose. Okay, stripping out because of the connection. Okay, so let's look at the functions of the lacrimal apparatus. So before we talk about the functions, let's look at the properties to understand the functions. So the properties of the lacrimal fluid, the tears themselves, the number one, they are made up of the dilute salt solution, which of course we call the tears. Those same lacrimal fluid also contains antibodies. Antibodies fight antigens or foreign substances. And you have lysozyme. This is an enzyme that destroys the bacteria. So those are functions. So if you say number one function is the function of the lacrimal fluid to protect. Protect against what? Okay, I'm going to say to help protect, fight antigens or foreign substances, or against also as enzymes that destroys the bacteria. You have now explained what we mean by protects. Then we have moistens, so it moistens the eye. Then we have lubricates, again lubricates what? The eye. Then lastly it empties into the nasal cavity. We talked about the nasolacrimal duct. So we have just talked about the function of what it has. So those are its function. So those are the function of the lacrimal apparatus. Okay. So the eye actually moves. If you can look up, you can look down, you can look laterally on the left side, you can look medially. Okay, so how does the eye do those things? So the muscles of the eyes are actually attached to the outer surface of the eye, and they are the ones which produce the eye movement. Okay, so when those extrinsic eye muscles contract, they are the ones which produce movement. So for instance, number one, we have the superior oblique muscle which causes the eyes to look out and down. Then you have the superior rectus which causes the eyes to look up. Then you have the lateral rectus which causes the eyes to look outward. Then you have the medial rectus which causes the eyes to look inward. Then you have the inferior rectus which causes the eyes to look downward. Then you have the inferior oblique which causes the eyes to look in and up. That is the inferior oblique. So together the muscles, we have the superior oblique, superior rectus, lateral rectus, medial rectus, inferior oblique. Okay, so that's what we have. And this is just a diagram which of course has been labeled, showing the roof of the orbit of the eye and which has been removed. And you have the superior rectus and the levator palpebrae superioris which have been severed. So now we are looking at how the eye is positioned in the eye socket and the muscles as well. But you have to know that the superior rectus and the levator palpebrae superioris have been severed. Okay, so we are done with the accessory structure. So let's go to how is the eye specifically. So we are now on the structure of the eye. Okay, so the walls of the eye are composed of three tunics. We have the fibrous tunic, which is the outer layer, which is the outside layer, the fibrous tunic. You have the choroid, which is the middle layer. Then you have the sensory tunic, which is the layer, which is an inside layer. Okay, so that's what you have to know. Then let's start with this fibrous tunic. So the fibrous tunic has a structure which we call the sclera, which is a white connective tissue layer, and it is one which is actually even seen anteriorly as the white of the eye. Then this same sclera is semi-transparent, so meaning the sclera is found in the fibrous tunic and some covers the outer layer of the eye, and it is always seen even anteriorly as when someone is looking in your eyes. So your eye are white, the eyes are yellow. So that's the one which is seen anteriorly before in pathology. If your eyes are yellow, of course, the pathology it's called jaundice. So, but if normal, it should be seen as the white of the eye, not the yellow of the eye. The yellow of the eye, that's now jaundice. Okay, so you can even check yourself to see whether it's white or it has changed color. Okay, then we have the fibrous tunic. So the fibrous tunic, of course, has the cornea. So this in front here we have the cornea. So the cornea is actually transparent and it is found on the central anterior portion. It also allows light to pass through or refracts or bends or light slightly. Then it also repairs itself easily. So the cornea repairs itself easily. And it is the only human tissue that can be transplanted without fear of rejection. So we are doing cornea transplants. This is the only human tissue that can be transplanted without fear of rejection, like most tissue. So the cornea is so meaning someone can have cornea transplant without fear of rejection. Again, someone asked me to say, okay, where are they going to find the cornea? Of course, I'm sure you know where they're going to find the cornea. Okay, of course you don't want to say very difficult to find someone who is able to see nicely, and those someone can donate as whilst they're still alive. But remember, we all have our eyes. So, but of course, if it's a relative, maybe they can donate a cornea so that at least they can be seen with the other one. That's also good. Okay, but someone just wondering how they never thought about donating, or they never thought about maybe someone who's maybe severely sick, and they, of course their eyes are just fine, and they say, okay, I think yeah, as I'm about to die, I think I'll consent for transplant of most of my organs. Okay, so this is the anterior view. This is the anterior view. You have the sclera, which is the white part. Then of course the cornea is the transparent, so of course we can't see it with ear, but of course you have to remember the sclera is only seen as the white, then inside of the cornea, but of course from here we can't necessarily label it. But you have to know that the sclera is the white of the eye, then you have the iris, which is this part, then in the middle of the pupil. Okay, so let's go to the choroid layer. So the choroid layer is the blood-rich nutritive tunic. It also has a pigment which prevents light from scattering. So in short, it is actually opaque, and it blocks light from getting in, and also has the melanin. So that's the choroid layer. I'm sure you have seen the certain colloids. So these are the colloids, the red part. Okay. Then you have the choroid layer continuation. So the choroid layer continuation, apart from knowing that it's a blood-rich nutritive tunic, also this same choroid layer is modified in, interiorly into two structures. We have also in short, we are talking about this. So after you have seen the choroid layer coming like this, it's made up of two structures. The other one is this, which is the ciliary body. Then the other one comes and makes the iris. See, this is what we were talking about. So the choroid layer was just coming nicely, then it's separated into two structures, where the iris and the choroid ciliary body. That's what we are saying. So those structures, the ciliary body is just a smooth muscle which contracts to adjust the shape of the lens. Then the iris is a pigmented layer that gives eye color. Then it also contracts to adjust the size of the pupil and regulates entry of the light into the eye. Then the on the middle of the two iris, so meaning you have the inferior one and the superior one, and then on the middle, that's where you have the pupil. So the pupil is a rounded opening in the iris. Okay. So let's go to the sensory tunic. The sensory tunic, of course, this is where the let's just get the retina, or that's the name of the sensory tunic, the retina. So the retina contains receptor cells. So these are photoreceptors. So the photoreceptor cells are two. You have the rods and the cones. Then the signals leave the retina toward the brain through the optic nerve. So you're saying after the information goes to the retina, the yellow part. And then the yellow part has rods and cones. After they transmit the information, just going through the optic nerve. Then optic nerve, then we are going to continue as in where this goes after the optic nerve. So the sensory tunic, which is the retina, after the information has been signaled, they pass from the photoreceptors via a two neuron chain. You have the bipolar neurons and the ganglion cells. So the signals are going to pass from these photoreceptors via the two neuron chain through the bipolar neurons and the ganglion cells. That's what we are saying. Okay, then let's move. So this is a part of the eye, and we're showing you the tonic, the retina as well. Then we have the visual pigments. So the visual pigments, remember I talk about the the parts of it. We'll talk about the rods and the cones. So here we are going to talk about the rhodopsin. The rhodopsin is a visual people which are in high concentration in the rods, and they are composed of the opsin and in the of course, and in the retina there's also a derivative of the vitamin A proteins. So meaning they are composed of the opsin and the retina proteins. So when light hits the protein, it bleaches and turns yellow and then colorless. It straightens out and breaks down into opsin and the retinol. Then there are three different other opsins besides the rhodopsin, with absorption for yellow green, which is the photopsin 1, green photopsin 2, and the bluish violet, which is the photopsin 3. The bluish violet light is the photopsin 3. So those are the visual pigments. Then let's now just talk about the neurons of the retina and the vision. So we are starting with the rods. So most of the rods are found toward the edges of the retina, and the rods allow dim light vision and peripheral vision. So meaning they are more sensitive to light and do not respond in bright light. Then perception is all in gray tones. So that's the rods. Then the rod cells, these are the rod cells. Okay, these are the rod cells. This is how they look like. So we have the convergence, and we have the rod bipolar rods. Okay, and the amacrines. Okay, so those are the rod cells. Then let's look at the neurons of the retina and the vision, but the other one. So meaning we talked about the rods, now we're talking about the cones. So the cones allow for detailed color vision, and they are densest in the center of the retina, and the fovea centralis is an area of the retina with only cones. We are saying there is an area in the retina which only has cones, which we call the fovea centralis. And this one responds best in the bright light. And there are no photoreceptor cells that are at the optic disc or blind spot specifically. There are no photoreceptor cells. So these are what we are talking about. Okay. A photoreceptor layer, which is here. And these are the rods and these are the cones. Okay, so there are three types of cones. We also have those same different cones which are sensitive to different wavelength. So we are saying there are three types of cones. We have the red, the green, and the blue. And these same red, green, and blue are also have different wavelength. So the red is long, the green is medium, the blue is short. Then you also have to know that color blindness is the result of lack of one or more cone type. For instance, someone is lacking the long one, so meaning they are going to lack the red color, so they won't be seeing the red color. Okay, so that's what you mean by color blindness. So how exactly do we see colors? So how do we see colors? So to see any color, the brain must compare the input from different kinds of cone cells and then make many other comparisons as well. So the lightning fast way of judging a color begins in the retina, which has the three layers of cells. Signals from the red and green cones in the first layer are compared by specialized red-green opponent cells in the second layer. These opponent cells compute the balance between the red and the green light coming from a particular part of the visual field. Other opponent cells then compare signals from the blue cones with the combined signals from the red and the green cones. So that's how we see is moreover a comparison. So is this what I'm seeing, green or yellow? So in short, when you are seeing a red part, the first layer, which of course has if you are seeing maybe yellow, so the first layer which has the red and green are going to compare and to see if maybe there's any balance with the comparison of the second layer. So but if what you're seeing is red, of course the same comparison is going to occur and it's going to find that okay, this is specifically red, then of course your brain will interpret it as red. Okay, that's what we are talking about. That's how the brain sees, the eyes sees. Okay, so there's one I said brain because it's one which actually interprets. Then let's go to color blindness. So color blindness is just an inherited trait that is transferred on the sex chromosomes, the sex specifically the 23rd pair, and you also have to know that the color blindness is a sex-linked trait, and it occurs more often in males. So remember, males have the XY chromosomes, so it is more linked on the X. So and men usually have one X, females have two X. So that's why it occurs more in female because they only have one X. So if a female has the sex-linked trait for the color blindness, since they only have one X, so meaning they are going to be sick, they are going to have color blindness. Okay, then this condition, color blindness, cannot be cured or corrected, and it comes from a lack of one or more types of the color receptors. So either they are lacking the red one, okay, the green one, okay. Then most are actually green or red or both, and that is due to a lack of red receptors. Then another possibility is to have the color receptors missing entirely, which would result in black and white vision. So meaning someone will just be seeing black and white vision. Okay, that is color blind. So they are what we call the color blindness test plates. So meaning we give someone these test plates and see if they can see all colors. So that's what we'll be doing. So I will be telling you the answers, or I'll be confirming with you what you are saying, just in case I also have color blindness, but of course I don't. But we'll be confirming together. So this, I hope you are also seeing 25, 56. This is 6. Okay, so if you're seeing 8, then yeah, you can't see green. Okay, because the 6 is in green. Then this is 29. It's definitely not 89. This is 29. Okay. Then this is easy. I think it's very visible. This is 45. Then this is 8. So that is the color blindness test plate. Okay. Let's go to the lens. So the lens is a biconvex crystal-like structure which is held in place by a suspensory ligament attached to the ciliary body, and it reflects light greatly. So the lens is this one, this part, which is held together by the suspensory ligament. The suspensory ligaments are coming from where? We are saying they are coming from the ciliary body. And what does the lens do? The lens refracts the light greatly. Okay. Then the eye has what we call the internal eye chambers. Of the aqueous humor, we have the aqueous humor. This is what we are going to start with first. The aqueous humor is one which is in the anterior segment. Okay, so this is an altered fluid found in the chamber between the lens and the cornea. The cornea is here, the lens is here. here. So in between here. Okay, and this one is similar to blood plasma. They act and help maintain intraocular pressure, and they provide nutrients for the lens and the cornea. And these are reabsorbed into the venous blood through the canal of the Schramm. Then next we have the vitreous humor. So this is a gel-like substance behind the lens that keeps the eye from collapsing. Again, that's why someone asked me to say, so if someone has trauma to the eye and only the aqua swimmer is affected, so meaning maybe the aqua swimmer starts dripping. Okay, if you manage to prevent from everything from going out, of course, someone may retain sight. But if it's a vitreous humor which has been affected, this one is one which keeps the eye from collapsing. So the eye will collapse immediately. The vitreous humor starts to leak out, and the vitreous humor found actually lasts a lifetime and is not even repressed. So that's what we are saying. So the vitreous humor is on this part. Okay, that's where the vitreous humor in the posterior segment. That's where we can find the vitreous humor. Okay, so let's look at the lens accommodation. So the light must be focused to a point on the retina for optimal vision. Then the eye is set for distance vision over 20 feet away. Then for a 20/20 vision, which is at 20 feet, you see what a normal eye would see at 20 feet. But if you are 20 and over 100, so meaning at 20 and you are someone is sitting is at 100 feet away, a normal person would see at 100 now. Okay, then the lens must change shape to focus for closer objects. See, that's what we are saying. That's what lens accommodation is. The changing of the shape of the lens in order to focus for closer or far away objects. See. Then we have conditions that have to do with sight. Number one condition that has to do with sight is called myopia, which of course is known as nearsightedness. So myopia is the difficulty in seeing objects at a distance. Then myopia occurs when the eyeball is slightly longer than usual from front to back. So this causes light rays to focus at a point in front of the retina rather directly on its surface. Then how do you correct myopia, nearsightedness? So this one you can use the concave lens to correct the problem. Okay. The next condition is hyperopia. So hyperopia, or also known as farsightedness, is when light entering the eye focuses behind the retina. So these are also known as hyperoptic eyes. So hyperoptic eyes are shorter than normal. Okay, and how do we treat hyperopia? We use the convex lens. Okay, so how are images formed on the retina? So if the image is focused at the point at the spot where the optic disc is located, nothing else will be seen. This is known as the blind spot. Okay, there are no photoreceptors there, as the nerves and the blood vessels pass through this point. Okay, so that's why if the image is focused at a spot where the optic disc is located, you can't see it because that's a blind spot. Okay, so let's look at the visual pathway. So after someone sees, where is the information going to go? And the other thing also have to remember is that the right eye takes information is an elongation of the left hemisphere. The left eye is an elongation of the, these have already been corrected. So we are saying this is normally the right eye, but it's actually the left. Why is called the left but from the right? Because of the optic chiasma, they are interchange. So the left eye is called the left because because of the brain on the left side. That's where it takes information. But this one is normally the left eye, but it's called the right eye because it takes information to the right side of the hemisphere. Okay, so that's why we say the right side of the brain, or talking about the hemisphere, controls the left side. The left side of the brain controls the right side. So even the eye is the same. The left eye takes information to the right. The right eye takes information to the left. Okay. Then what are we saying exactly? So remember we said photoreceptors are found in the retina. So the photoreceptors that are found in the retina have to take the information to where? The optic nerve. After they take the information to the optic nerve, then the optic nerve crosses at the optic chiasma, which is this side. So we are saying photoreceptors in the retina takes information to the optic nerve crosses the optic chiasma where they now interchange. That's what we are saying. Okay. So from the after they interchange from the optic chiasma, then they make optic tracts. Then optic tracts, then of course they find specifically where they are going to go. Number one is the thalamus, where the axons form the optic radiation. Then from the thalamus, they are going to go to the visual cortex of the occipital lobe. So recap what you're saying is from the optic, from the retinas of the eyes, the optic nerves, the optic nerve, the optic chiasma, you have the optic tracts, you have the thalamus. Thalamus, you have the visual cortex of the occipital lobe. Okay. Then let's look at the eye reflexes. So the internal muscles of the eyes are controlled by the autonomic nervous system. So for instance, when someone is having bright light, it causes the pupils to constrict through action of radial and ciliary muscles. Then viewing close objects also causes the accommodation. Then you have the external muscles which control eye movements to follow objects. So this is usually voluntarily and controlled at the front eye field. Then viewing close objects causes convergence or eyes moving medially. Okay, those are eye reflexes. Then we talked about the hyperopia, myopia. The next we're going to talk about other eye conditions such as cataracts. So in youth, the lens is transparent and hardened gel-like texture. As we age, it becomes increasingly hard and opaque. Hence, they develop on it what we call cataracts. So here in this picture, you have seen that the lens is crowded by cataracts. So a cataract is an opacity of the normally clear lens, which may develop as a result of aging, metabolic disorders, trauma, or hereditary. That's what a cataract is. So cataracts cause vision to become hazy and distorted, and eventually can cause blindness. Risk factors for cataracts of type 2 diabetes, exposure to intense sunlight, heavy smoking. Then current treatments for cataracts, we have the surgical removal, we have replacement of the lens, implants, or specialized glasses. Okay, so this is cataract surgery where we actually remove the cataracts. Okay, so we remove of the cataracts. The next condition is glaucoma. So glaucoma occurs when the drainage of the aqueous humor is blocked, or the fluids back up, and the fluid backs up. So meaning after the aqueous humor drainage is blocked, then the fluid actually will actually back up. So meaning to increase the pressure in the eyes. So pressure on the eye increases, compressing the retina and the optic nerve. Hence the condition is called glaucoma. So the normal eye is like this, but in glaucoma the fluid back up and increases pressure and push it, and after the pressure has been increased, it compresses the retina and the optic nerve. Then glaucoma causes pain and possible blindness, and it progresses slowly and painlessly until the damage is done. The tonometer is used to test for intraocular pressure. So use a tonometer. Okay. Then glaucoma is commonly treated with eye drops that increases the rate of drainage. Specifically, we use in our setup we like to use Timoro 0.5, but of course there are also others. Then we have laser or surgical enlargement of the drainage channel can also be used. Okay. Then we also have other tools that we use that in other conditions, not necessarily the glaucoma. So other instruments we have is what we call ophthalmoscope, which is an instrument used to illuminate the interior of the eyeball, and it can be used in conditions such as diabetes, arteriosclerosis, and degeneration of the optic nerve and retina. And this one can be detected by examination with an ophthalmoscope. These ones. Okay, so this is an ophthalmoscope which you are seeing here, and this is after passing light through it so that you can see. Okay, even hypertensive retinopathy, you can also use an ophthalmoscope. Okay, and these are some of the findings. These are some of their findings. Okay, after using a digital ophthalmoscope camera. So this is a digital ophthalmoscope camera. Okay, and some of the findings, but of course this is anatomy and we won't necessarily go into the findings of the pathologies. It's okay. Let's go to the E. So in short, we are done. In short, we are saying we are done with the eyes. So meaning we are done with one special sense. Let's look at the ear. The ear the ear houses two senses. You have the sense of hearing, which is interpreted in the auditory cortex of the temporal lobe. Then you have the sense of equilibrium, which of course is balance, which is interpreted in the cerebellum. Then these receptors are mechanoreceptors, but different organs house receptors for each sense. So meaning in the ear we have an organ of hearing and an organ of equilibrium. So meaning that's what they mean. Okay, so let's look at the anatomy of the ear. So the eye is divided into three areas. You have the outer, which is the external ear, the middle ear, which is the one which is on the middle part. Then you have the inner ear, which is in the internal part. Okay, so these are the three areas of the. Then the external ear. So you are starting with the external ear. This one is only involved in hearing only, and it has the structures of the external ear. We have number one, the pinna, which is the auricle which collects sound. The pinna, the one which you can actually touch outside. Okay, and we also have the external auditory canal, which channels sound inward. The external auditory canal. So we talked about the pinna or auricle, which is outside like this. Then you also have an external auditory canal. So the canal itself is one channel sound inward. Then you have the external auditory canal, which narrows the chambers in the temporal bone through the external auditory meatus. Then this same external auditory canal is actually lined with skin, the same skin, which of course we can see on our forearm. Then also this on the same external auditory canal, they are what we call the ceruminous glands, which produce wax. So the wax is the one which comes out, of course, the one which you see. Then the ends of the same external auditory canal acts at the ends at what we call the tympanic membrane or the eardrum. So that's where the external auditory canal ends. Okay, then we are done with the external. So what about the middle ear? So the middle ear or the tympanic cavity is an air-filled cavity within the temporal bone, and it is only involved in the sense of hearing. So talk about the external one, say okay, it's also involved in hearing alone. Even the middle also involved in hearing. Then the middle ear or the tympanic cavity has two tubes that are associated with it. It has two tubes. So the first tube actually is the opening from the auditory canal. It is actually covered by the tympanic membrane. So meaning the first tube is the one which actually goes and connects with the inner ear. So but that one is actually one which is covered by the tympanic membrane. So from the tympanic membrane, then you are going to find the inner ear. Then the other tube is the auditory tube, which connects the middle ear with the throat. Okay. So this tube is also known as the eustachian tube, and it allows for equalization. It allows for equalizing pressure during yawning or swallowing. And this tube is otherwise collapsed in most instances. Okay, but during swallowing and yawning, then of course it's going to equalize the pressure. Okay, so what are the bones of the tympanic cavity? Tympanic cavity or the inner ear. So the inner ear has three bones. Okay, that span the cavity. Number one of the malleus is also known as the hammer. Of the incus, which is known as the anvil. Then of the steps, which is known as the stirrup. Okay, so this is what we are talking about. This is the tympanic membrane, which is the eardrum. Then after the eardrum, you have the cavity, the tympanic cavity. And the tympanic cavity, we have bones, three bones, bone oscos. Okay, the osco number one, we have the armor, which is the malleus. Then the second one is the anvil, which is the incus. Then lastly, we have the stirrup, which is the steps. These are the bone oscos that are found in the middle. So these are the ones we are seeing from here. And they are actually very, very small. And if you have seen, they are put on a coin, and they even just didn't even occupy a lot of space. So the same bones of the tympanic cavity, when when someone is hearing and there's vibration occurring, so those vibrations from the eardrum moves the malleus. So okay, so when the eardrum is vibrating, it's going to move the malleus. Then these bones, as they are moving, the waves are also passing. So they transfer sound to the inner ear during the vibrations. Okay. So we are saying after the eardrum causes vibrations, then the vibration moves to the malleus, then of course the vibrations are going to continue, and thus the waves will travel to move from there, and that's also how the sound will transfer from the middle to the inner ear. Okay, so let's go to the inner ear. The inner ear is also known as the osseous labyrinth, which is a twisted bony tube and it includes sense organs for hearing and the balance. Remember, from the middle and the outer, you are only talking about the sense of hearing, but the inner ear has sense of hearing and the balance. Then this same bone labyrinth or the inner ear is filled with perilymph. It is filled with the perilymph. So remember, the last bone which was in contact with the inner ear was the steps. So vibration of the steps push and pull the membranous over window, moving the perilymph from the cochlea, and the round window is a membrane at the opposite end to relieve pressure. So the round the over window which is here. So when the steps vibrate, they outside push the perilymph. Okay, that's how they move. The last three, you have the round window, and you are saying the round window is just a pressure at the opposite end to relieve the pressure which was initiated. Okay, that's what we call as the labyrinth. So this is the reason why it's called the labyrinth, because of how the passage is. Okay, so we have the round window, we have the oval window here, we have the round window here. Then you have the scala vestibular here, and you have the scala tympani here. Then you have, of course, this is just the basilar membrane. Then you have the cochlear duct, which is here. Okay, and these are some of the structures that we need to bear in mind next. Okay, so let's look at the inner ear or bone labyrinth specifically. Okay, so this is actually a maze of bony chambers within the temporal bone. Okay, and it has a cochlea, it has a upper chamber which we call the scala vestibuli, like we said this is a scala vestibuli. Okay, then the lower chamber is known as the scala tympani. And then you have the vestibule, then you have the semicircular canals. So they are the semicircular canals. Okay, then the vestibules. So let's look at the organ of Cort. So the organ of Cort is located within the cochlea, and it has receptors, and those same receptors have air cells on the basilar membrane. So we are saying the receptors of the organ of Cort are just air cells on the basilar membrane. Okay, that's what we are saying. The same receptors are air cells, and those are the organ of the receptors of the organ of Corti are air cells. Okay, then the organ of Corti is the gel-like tectorial membrane, which is capable of bending air cells, and the endolymph in the membranous labyrinth of the cochlear duct flows over it and pushes on the membrane. Okay, that is the organ of Corti. Then the organ of Corti also, after the air cells, remember that we said air cells moves to catch the impulses or to catch the stimuli. So after they have caught the stimuli, then of course you have to know that the cochlear nerve are actually attached to the air cells, and they transmit nerve impulses to the auditory cortex on the temporal lobe. So I repeat, we are saying the air cell receptors, the air cells are the receptors of the organ of Corti. And once they get the information, remember they have what we call the cochlear nerves that are attached to them. So once the information gets to the cochlear nerve, the information is transmitted as nerve impulses to go to the auditory cortex of the temporal lobe. That's what we are saying. So information is so the stimuli is detected by the air cells of the organ of Corti. Then the organ of Corti as attachment with the cochlear nerve, which transmits the nerve impulses to the auditory cortex of the temporal lobe. And this is the organ of hearing. So that you are able to hear because of the organ of Corti, which is the organ of hearing. So what are the mechanisms of hearing? So we talked about vibrations. So what do the vibrations do? So vibrations from the sound waves move the tectorial membrane, and of course when they are moving, they pass through the endolymph fluid, feeding the membranous lymph, feeding the membranous labyrinth in the cochlear duct. Then the hair cells are bent by the membrane, and of course when they are bent by the membrane, the information is detected. Okay, and after it has been detected, it's going to be transmitted and integrated through the cochlear nerve. That's what we are saying. Let me repeat. We are saying there are vibrations. Remember, vibration we are coming from the inner ear. Then the inner ear, of course, the vibration are going to move the tectorial membrane, and they are going to pass through the endolymph fluid, feeding the membranous labyrinth in the cochlear duct. Then, of course, we have the organ of course there, which are the air receptors, which are the receptors to get the information. Okay, and once the air receptors are bent by the membranes, they detect the information. And why do they take the information? They transmit it and integrate it on the cochlear nerve. Okay, so that's what we are saying. So after the air receptors are bent, an action potential starts in the cochlear nerve. Then the signal will be transmitted to the midbrain for auditory reflexes, and then directed to the auditory cortex of the temporal lobe. Okay, then of course someone will be able to. Okay, then of course continued stimulation can lead to adaptation. Then overstimulation to the brain makes stop interpreting the sound. That's what we are saying. Then we are done with the organ of hearing. Let's look at the organ of equilibrium. Organs of equilibrium. So organs of equilibrium, of course, are the receptors. And those receptors are in two structures. You have structures such as the vestibuli. The vestibuli is one which has receptor cells. Then the other structure such as the receptor cells, the semicircular canals. Semicircular canals are the receptor cells for the organs of it. Then equilibrium has two functional parts. Since we said it has two functional parts. Even the receptor cells that we said they are also found in two structures. So the first part is static equilibrium. The second one is dynamic equilibrium. So the static equilibrium is found in the vestibule. Then dynamic equilibrium is found in the semicircular canals. So that's how different the organs of equilibrium are. The one said they have receptors in two parts. So the receptors in the vestibule, receptors in the semicircular canal. Even the function we are saying there are two. We have the static equilibrium and the dynamic equilibrium. Then the static equilibrium is found in the vestibule. The dynamic equilibrium is found in the semicircular canal. Okay, so let's look at the static equilibrium. So we have the receptors in the vestibules, which we call the maculae. So the maculae are the receptors in the vestibule, the ones which are able to do static equilibrium. Then those same maculae actually report on the position of the head. Okay, static when someone is not moving. Okay, static when someone is not moving. Then they send information via the vestibular nerve. So in short, we are saying, okay, this is the vestibule. Then inside the vestibule, you have the otolith. The otolith, again, below the otolith, you have the otolithic membrane. Then those same membrane have a connection with the vestibular nerve, and that's how they are going to report on the position of the head. If you move the head out of position, then you have already gone into dynamic equilibrium. But if you are standing still, then of course the position of the head is one which you are going to use to make you stand still or sit still or lie still. Okay, then let's look at the anatomy of the macula. I've already touched most of the anatomy of the macula, which is more of a repetition. So anatomy of the macula, you have to know that the macula has air cells that are embedded in the otolithic membrane. So we have the air cells. These are the air cells here, okay, that are embedded where in the otolith membrane. Then also we have otoliths, which are tiny stones, the ones which are up above, the ones which are looking like clouds. Those are otoliths. They float in a gel around the air cells. Okay, those are the otoliths. Then what are the functions of the macula? The macula function is that the movements of the macula the movements causes the otolith to bend the air cells. So the gravity moves the rocks over and pulls the airs. So remember, you said the otoliths are floating in the gel-like substance. So when the gravity when the edge moves, also remember the gravity also moves. So the otoliths, which are stones which are rock-like, when they actually move out of position, they also move over and pull the airs on the macula. That's what we are saying. So hence they are the receptors. That's what we meant. Okay, so that's what the receptors. Then let's look at the dynamic equilibrium. So we have talked about the static, the macula. So the dynamic equilibrium, so the whole structure is the ampulla of the dynamic equilibrium. The whole structure is the ampulla. They have the crista ampullaris, which is the receptors in the semicircular canal. Remember, in the static of the macula, then in the semicircular canals, we have the crista ampullaris, and the crista ampullaris has the tuft of air cells as well. Okay, that's what we are saying. The semicircular canal, and this is how the semicircular canal is. Okay, and this is the ampulla. Then the ampulla has a tuft of air cells. Okay, so dynamic. So dynamic is has to do with motion. So which motion do we use? So they use the action of the angular edge movements. So the cupula stimulates the air cells, and there's going to be movement of the endolymph, which is going to push the cupula over and pulls the airs. Then an impulse is sent via the vestibular nerve to the cerebellum. Okay, that's what we meant by the dynamic equilibrium. Okay, and these are just structures showing you the structures for the vessel. Then we are done with the ears. So meaning in the ears we have talked about both the sense of hearing and the sense of balance. Okay, we are done with the two senses. Now let's talk about the chemical senses. So chemical senses we have two. We have the sense of taste and the sense of smell. So both of these senses use chemoreceptors, that's why they are called chemical senses. And they are stimulated by chemicals in solution. Then taste has four types of receptors. Smell can also differentiate a large range of chemicals. Then both senses complement each other and respond to many of the same stimuli. Okay, so the first sense we are going to start with is the sense of smell, which is the olfaction. Okay, so the sense of smell, we have the receptors, which we call the olfactory receptors. The olfactory receptors are found in the roof of the nasal cavity, and the neurons have what we call the long cilia. So the neurons of the olfactory site have a long cilia, and their chemicals must be dissolved in mucus for detection. So they are saying the chemicals have to be dissolved in mucus for them to be detected. Okay, for you to smell something, it has to be dissolved in mucus. Okay, so impulses are transmitted via the olfactory nerve. After the chemicals were dissolved in mucus. Then that's when were detected, and after they are detected, an action potential will be generated, and the impulses will be transmitted via the olfactory nerve. This is what we are saying. After the olfactory air, the cilia, it takes the information, it has to take via the olfactory nerve. Okay. Then from the olfactory nerve, it has to be the interpretation of the smells is made in the cortex, specifically in the olfactory area of the temporal lobe. Okay. So these are olfactory cells, what we are talking about, and this is the cilia that we have. So the air that you see in the nose actually is used for smell. Okay. So we are done with the sense of smell. Let's go to the sense of taste. So the taste buds house the receptor organs. So this is the sense of taste. We are now on the tongue. The taste buds house the receptor organs. Then the location of the taste buds, so most are on the tongue, and of the soft palate and the cheeks. Okay. So location of the taste buds, we are saying most taste buds are found on the tongue, others are found on the soft palate, then others on the cheeks. But most of the taste buds are on there. So let's look at the anatomy of the tongue. So the tongue is covered with projections called papillae. Then there are three types of papillae. We have the filiform papilla, which are sharp with no taste buds. We have the fungiform papilla, which are rounded with taste buds. Then you have the circumvalent papilla, which are large papilla with taste buds. Then the taste buds are found on the sides of the papilla. Okay, that's what you need. Okay, so that's what we're talking about. We have the fungiform, we have the filiform. Okay, these are buds. So let's look at the structure of the taste buds. So the taste buds also needs to have receptors. So the gustatory cells are the receptors of the taste buds, and they have what we call gustatory hairs. So they are the one which actually detect the stimuli. The gustatory hairs are the long microvilli. So the hairs are stimulated by the chemicals dissolved in the saliva. So that's how they also detect the information. So in short, we are saying saliva, after you eat something, of course, it's dissolved in saliva. Then saliva, the gustatory hairs detect the information, take to the gustatory cells. So the gustatory cells have structures which we call the long microvilli, and those are what we call the hairs specifically. Okay, the gustatory hair. Okay. So after the gustatory hair detects the information and takes the cells, the impulses are carried to the gustatory complex. From the gustatory complex to go to the palatal lobe by several cranial nerves. Why several? Why not just one cranial nerve? Because taste buds are found in different areas. For instance, the facial nerve, the glossopharyngeal nerve, and the vagus nerve. That's why the taste buds don't take information from one part alone, no. They don't transmit impulses from one part. They transmit the impulses by several cranial nerves, such as the facial nerve, glossopharyngeal nerve, and the vagus nerve. So let's look at the taste sensations. So how is the taste sensation distributed on the tongue? So you have the sweet receptors, which you have the sugars, the saccharine, and some amino acids. So the sweet, we have the tip of the tongue can detect sweet. Okay. Then we have the sour receptors of course, for acids. Okay. Maybe you're eating lemons or something. So the sour receptors are found laterally. Okay. Then you have the beta receptors for alkaloids. Okay, these are alkaloids. Then of the salty receptors for meta ions. The salty receptors are here, but if you have seen that there's a communication. For instance, the sweet and the salt also communicates on a certain area, but specifically the tip is only for sweet. Then the lateral parts is for sweet and salt, so meaning in between. Okay. Then lastly we have umami. Umami, this is the glutamate, aspartate, and this is for sweet, savory sensation or flavor, and specifically for meat and other sweet, savory uh, foods that we can eat. So, let's look at the developmental aspects of the special senses. So, we are also done with the tests. So, let's look at the developmental aspects of the special senses. So, the special senses are formed early in the embryonic development. Then the eyes are outgrowth of the brain, and the left brain outgrowth goes to the right side. The right brain, its outgrowth goes to the left side. Then also, all special senses are functional at birth. Okay, all special senses are functional at birth. Okay, so even a child can see just that the vision, the one which is known to that good. So I mean the vision is not good when child is born. So I mean that's why they say newness don't see when they are born. Not that the special senses don't function. The vision is not just that good. Okay, that's what you need to understand. Okay, so this is the checkpoint. If you have any other question, you can put in the comment section. But otherwise, yes, we are done with the special senses. And remember the other sense, which is for the skin, we have done it in the integumentary system. So of course, we didn't necessarily touch it because it could have been a long lecture if we added the skin. But of course, I thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification. And of course, this is the last video on the nervous system. Next, we are going to do the embryology, general embryology, not the entire embryology. No, just the general part. Okay, all right. Thank you.